very good afternoon, lunchtime, but uh, we have some interesting talks lined up, trying to choose between the correct refractive procedure. We all understand that we now have many good procedures available to us, unlike 20 years back when we started with PRKs and went to LASIK and then came back to the surface, and then now we have like lenticules have taken a lot of interest. We have topo-guided LASIK, like the Contoura kind of procedures. We still have a lot of developments with PRK. And yes, phakic lenses have also now become very, very popular. And today's course will try to tell us that when and how to use each of these procedures and how to use them rightly. We have a stellar faculty with us, Dr. Kumar Doctor from Bombay, Dr. Mahipal Sachdev, Dr. Pooja Kamar, Dr. Chitra Ramamurthy, and Dr. Shivani Patnaik. And they will be covering, this is the scope of the course. So we will be having myself, I'm Gaurav Luthra, and have about 20 years of experience with laser correction and ICLs as well. So this is how we'll go. So there's a little bit of change in topics and speakers because of clashing sessions, but we will be covering the extra procedures and as well as femto and microkeratome LASIK, whether they still have any takers. PRK, PRK extra and smile extra as well as phakic lenses. So going on, I think we have seen how refractive surgery has been evolving over the years, and it's been an amazing journey. And in fact, 2000 onwards, there has been so much development. Till 2000 was a very slow process, and today we have so many options when a patient comes to you, and we have to be careful not to push one procedure to all our patients, because each patient might deserve one of these procedures, and should be given a choice, and the surgeon should be able to decide what might be best for a given patient, rather than selling one particular procedure over everything else to every patient. FDA approvals came in starting about 25-30 years back. PRK, from you can see a big range of approval from -12 to +6, with up to 6 diopters of astigmatism. LASIK, again, similar approvals. Smile was approved only up till -8 for sphere initially, and total of 10 diopters of spherical equivalent, including astigmatism, and up to 3 diopters of astigmatism for myopia. Hyperopia approvals are still in the process for many years, and I'll invite Dr. Shivani up to the dais. Phakic lenses have become very popular. They took time for getting FDA approvals, but we were using them again for almost last 18 odd years in India, and much before that in Europe. The one current generation one, and of course before that we had the Veriflex and the Verisize, and our own Indian version of the Iris Claw lens. Dr. Daljit Singh was using it almost 30 to 40 years back as a phakic lens as well. And of late, with advances in cataract surgery, RLE or refractive lens exchange has picked up a little bit as well, and it remains controversial, but if we do the right case selection, again it's a very good tool. So these are some of the procedures. Now when I write smile, this slide is probably more than a year back, when there was only one lenticule procedure. Now we have several. There is Atos, there is Elita, and they've all taken a lot of interest. Almost all manufacturers have got into the K-Lex technique or the lenticule removal procedures, and they are gaining ground because of a lot of advantages. In my practice, almost 70% is now lenticule extraction. Contoura LASIK, again, a remarkable tool. I mean, Contoura is just one brand, but topo-guided LASIK for virgin eyes became very popular over the last 7-8 years, and caught the fancy of a lot of patients with a lot of aggressive marketing. So a lot of patients come and ask for Contoura when many of us may not have it, but one has to be able to know whether when to use it and when not. You can't be using Contoura for every patient. And then of course the other procedures. So selecting the right procedure could depend on several things: availability of equipments in your practice, or how you might want to use somebody else's equipments for your surgery. Surgeon would have their own preferences. So some surgeons might want to, in their hands something might work better. They may have more confidence on a procedure, and they might want to do that more often than others. Sometimes it's the patient who wants a particular procedure, and they will come and ask you that this is what I want. And sometimes even if they are qualifying more for something else, you might end up doing something that they are very keen for if it doesn't work against them. And then of course the most important thing is the patient parameters and indications. So a good thorough evaluation of the patient, a good chair time with the patient, trying to understand why they are looking for refractive surgery, would also become very, very important in this decision making. And as I already said, you could have self-owned equipment, shared facilities, an existing facility, eximers, microkeratomes are going away, but it's still around in many centers. Femtosecond lasers and the lenticular extraction and phakic lenses. So I think with this I would like to move on and come to what I'm speaking for today, because the first speaker is stuck in another session and has requested me to speak instead as the first speaker. So there is this Contoura LASIK which is popular and has been in India, has taken a lot of popularity over the last 5-7 years with aggressive social media marketing. And as we all understand, contour is an outline representing the shape or form of something. So Contoura is basically a topography guided reshaping of the corneal surface, along with that correcting the refractive error. So it goes beyond just correcting the refractive error and trying to give you a better corneal shape to give you better quality of vision. So femto-LASIK treatment options could be wavefront optimized, and which doesn't treat any of the pre-existing higher order aberrations, and that's the standard LASIK procedure which almost all machines offer today. We were doing wavefront guided treatments a lot in the past. It was very popular with that abrometer assisted customized wavefront guided treatment somewhere in the 2000s. Before 2010 they really caught the fancy, but as all of us realized that they were not really doing a great job in giving patients any major benefits, and they were unpredictable as well, because they depended on the pupil size. Aberrations change as the pupil size changes, and also lenticular aberrations, if you're trying to correct on the cornea, does not make sense. It does not work that well. We also did a lot of Q value based treatment, especially for presbyopia. You could customize the Q value for better quality of vision, depth of focus, and they were also being used for giving micro monovision by adjusting, making the cornea more prolate, and the FCAT treatments on the wavelight laser, but by different names on other lasers. You can customize them. And then of course topography guided is not new. It's been around on the Zeiss platform and on the wavelight platform for 15-20 years, and we were doing again topography guided even before Contoura was born. So how was Contoura born? That's a brand which came up when Alcon decided to launch this for virgin eyes. So essentially why Contoura came up was that the US FDA insisted on Alcon first proving that it is safe in virgin eyes before being offered to patients who required topography guided treatment. So a trial was done where they essentially did topo guided treatments on virgin corneas which did not have any significant aberrations, to do a superiority trial whether it was equivalent or better. And what they found was that when they combined topography guided treatments with the surface with the optimized treatment, they found that the results were much better. So that's where Contoura was born, and was introduced to the market about 7-8 years back. It utilizes the topographer, which is the wavelight topolyzer Vario, which will give you send the data to a treatment planning system, and that will further send it to the machine, and then you can just check all the parameters, and we'll come to that a little bit. So it's a topography guided treatment for virgin corneas, and we've already heard about how FDA did this for Contoura, and it treats pre-existing higher order aberrations on the cornea by doing topography maps. It prevents induction of new higher order aberrations as well, and it's based on corneal wavefront, and so it's not influenced by the internal wavefront of the lens or other things inside the eye. It's also independent of pupil size and accommodation, and it is centered on the corneal vertex rather than the pupil center. Most lasers will fire, the trackers will be basically firing on the center of the pupil, not on the visual axis, whereas these treatments are centered on the corneal vertex, so more likely to be very close to the visual axis of the patient. And how Contoura is different from wavefront optimized is that wavefront optimized only treats the refractive error of the patient using the keratometry readings to customize it for each patient, whereas Contoura would also goes beyond that by correcting the aberrations on the cornea, ending up with better results for the quality of vision of the patient. And of course, we already discussed that wavefront guided was not the best way to go, because 70% of the aberrations are basically from the cornea and not from the inside of the eye for young patients. And wavefront guided basically considers higher order aberrations of the whole eye, including the lens, whereas we are treating on the corneal plane, so it is actually counterintuitive and that is why now topography guided is more popular than the wavefront guided, which has lesser indications today. So when Contoura was launched, actually Alcon came up with some nomograms, and there were strategies, because in 2017 they advised that surgeons should calculate treatments based on the patient's manifest refraction, and also they were, the patients were not getting great visual acuity results as they would want, and an effort was then made to treat completely off the measured anterior corneal astigmatism. So the TMR system, or the topography modified refraction, was developed by John Canelopoulos to begin with. And however, there were cases in which treating the full topography guided manifest refraction led to the axis being flipped. So, there will be times when your manifest refraction is at one axis, say at 180, whereas the topography guided is trying to treat at 150 or 120. So if it is off by more than 10 or 20 degrees, you'll end up with a very, very significant poor result. So seeing that, some of the surgeons began to treat only 50% of the difference between the manifest refraction and the measured astigmatism. Measured basically is from the topography. So ideal candidates for Contoura, it says 18 and older because that's what the FDA trial said. But I personally would prefer to see refractive stability beyond 18 years of age till about 21 today. And we don't like to operate even right till 25 if refractive stability is not achieved. There is no urgency to do refractive surgery. Virgin corneas, and then you have the approvals, as you said, for myopia and astigmatism, up to 3 diopters of astigmatism and -8 to begin with. And today you can do much more. And good maps. Now that is the key. If you are going to do a Contoura treatment, you have to have topography guided. You have to have very good captures of the data on the cornea. So what you would not want to do is enhancements, poor quality maps, stromal scars, PTKs, lenticular changes, and cataracts. So if you have a lot of corneal aberrations other than the ordinary, which means non-virgin eyes, it might be a good idea to just do a topo-guided treatment rather than a Contoura. So step 1, as we already discussed, is topography, which should be reliable, and they take 6 scans, which should be reliable scans. You should not include scans which are not of good quality. I'll show you what would be a good quality scan. And this is a good scan because you can see that it is covering up much of the cornea over here except some of the superior where the lashes and the lid is. Now this would not be a great scan. You can see there are a lot of areas of dropouts. Even in this area the scan is not good. So these scans may not be good for treatment and should be excluded. And of course poor topography scans will also be marked out by the laser itself, telling you that the quality of the scan is not good for a 6.5 zone, only good enough for a 5.5 zone as is here. So once you have these scans available, then you can select the ones which you want to include in the treatment, because then the machine will average out these scans and create a treatment plan. So once the planning is on to the planning stage, we get a set of values, and it says that the measured, that's basically from the cornea's topography what we are measuring as the sphere and the cylinder and the axis. So this is how it looks. You can have these 6 scans, it's averaging out them, and then it is giving you a median Ks and the measured treatment. So this is what the, this is the subjective refraction of the patient, and then once you've fed this and gone to the Contoura topo planning, then you will get the measured, which is the second row. So for example, your refraction is -6.75 with 1 at 20, but the measured is spherical, of course, does not matter from the corneal measurements, but it's measuring a 1.6 astigmatism at 12. And then you have to decide in the bottom row what you want to feed as the final treatment plan. Now how do we do that? We first put 0 into the treatment plan, and as soon as you put 0, it basically removes all the refractive error from the treatment plan and gives you only the aberrations. So once you know what are the aberrations, then you can do the planning. So let's not go into details of the planning because that's beyond the scope of today's talk. But once you have these measurements and you compare it to the manifest refraction, you can decide if they are matching up, if the astigmatism cylinder is matching up with what you got on topography. Things become very easy because then you just go ahead with the treatment. It's much simpler. But when the astigmatism magnitude or the cylinder or the magnitude or the axis of astigmatism is not matching up with between the manifest refraction and the topography, then you have to decide what you would like to do. And here comes a very useful method at the bottom here. So there are several ways. As I said, option 1, you can treat the manifest with tight constraints. You can treat the measured cylinder and axis, making adjustments for the spherical equivalent. So what all we went through over the first few years of Contoura, but what we eventually do today is the Forcides software, which helps us do the planning. This is a proprietary software which for Indians it comes free from the US by Dr. Mark Lobanov on request. So it's basically like a geographic imaging software for refractive surgery, It's a very useful software. You just basically, utilizes the concept of talus, which is basically the secondary elevations on the primary elevation of the cornea. And each of these aberrations would actually be inducing their own refractive errors, so you would want to treat them. So essentially you can see here that it is trying to treat the aberrations by doing, these are the taluses which you can see in purple. I'll finish within 2 minutes. And it utilizes measurements from the anterior corneal astigmatism, it utilizes the talus astigmatism, it also utilizes the posterior corneal astigmatism from the pentacam, and it utilizes the internal astigmatism as well from the refraction, and then comes up with a treatment plan. I'll just show you this case which will help easy understanding of how the Faucet's works. A 22 years old male with very high astigmatism, and these are the patients which will really benefit for Contoura treatments because it is also correcting, it has cyclotorsion control, it does iris registration. So you will actually treat on the corneal vertex with cyclotortion control. This patient had a -1 with -6 at 20, and the other eye -1 with 5.25 at 155. And the Ks were matching up with the much of the astigmatism. So basically patient with high astigmatism but symmetric bow ties and a fairly good pachymetry. The Bellin maps was also normal. These are the scans, and you can see that they are quite fairly good symmetric maps in both eyes, and the eye trace showing up also that the maps are fairly consistent. The aberrations are, internal aberrations are very few, mostly on the cornea, high astigmatism for this eye as well as the other eye. So this gives you the comfort that you are on the right track doing a Contoura treatment. Epithelium maps and anterior maps also good enough. So what should you do? You could do a toric ICL for high astigmatism, or you could do a Contoura LASIK over here. So we went ahead with the planning on the Faucet's, which, as I told you, takes data from the pentacam, from your refraction and from the topolizer, and comes up with a treatment plan at the bottom here. So it is suggesting we treat 1.2 sphere with 5.5. This is the manifest, 0.75 sphere with 6 at 20. It has suggested that we do a 1.2 sphere. It's cut down the cylindrical treatment to 5.5 at 19. So this is a very kind of no nonsense kind of a thing which helps you make these treatment plans. We went ahead with the treatment, and this is the post-op cornea's shape, which comes out pretty good. Patient got an excellent result for both eyes and was almost 6 parts on day 1 with very good astigmatic corrections. So these are very gratifying results. We've been using Contoura and Faucet's for almost 7 years now, and for select cases where there are high corneal aberrations. So I'll skip this case number 2. It has transformed Contoura treatments.
Gaurav, you have time.
I'm done.
Other speakers are taking time.
I had 2 talks, so I'm just putting.
No, you have time. I'm saying you have time. Other speakers are getting late.
Shivani is here already.
No, Shivani doesn't have a presentation. She's going to get it.
Oh my God. Okay. We'll have a small discussion. So when to choose Contoura over Smile? I also like to, while hyperopia does not work with Faucet's, but if you want to treat on the corneal vertex, now hyperopia as well requires, we end up having angle kappa, which compromises hyperopia treatment. So when you're doing a topography guided treatment, in fact, John Canelopoulos did a lot of work on topo guided treatments for hyperopia, and it tends to treat on the visual axis or the corneal vertex rather than on the pupil center. So when you must have realized that all of us who do refractive surgery, we end up decentering our hyperopes because of the significant angle kappa. That is no longer required when you're doing a topography guided treatment. So hyperopia will do well if you're trying to do a topography guided treatment. Any thoughts on that, Kamal? On your machine, what do you do?
Same thing, visual axis.
So yeah, visual axis, right? So also high astigmatism, as you saw, our results for high astigmatism improved drastically with using the topo guided part, because basically what the topo guided is doing, that it's also checking for the corneal astigmatism and the manifest, and then trying to get the best outcome, trying to combine both of them and seeing whether it works well. Also, when you have very high corneal aberrations and coma, etc., you will have better results with topo guided treatments, and if the patient wants it. Now this is something which is a new thing for us. Social media and a lot of Googling has given patients that knowledge that they think that they know better than the surgeon who's actually going to perform the surgery, and they go shopping, and then they eventually come and say, okay, I want to do this. And sometimes it becomes very difficult. You have a patient who has predominantly sphere, almost no astigmatism, hardly any corneal aberrations. I would obviously offer that patient a Smile, something like a -5 or a 6 sphere patient. They come and ask that they want Contoura. You try to explain to them that, unnecessarily I'm going to cut a flap on your cornea, weaken it, and you're not going to gain from a Contoura treatment in any way. And Smile would be an ideal treatment, but patients sometimes feel that the doctor has some personal interest, so it becomes very difficult, and sometimes you have to eventually say, okay, if you are so keen to do it, as long as it's not hurting you, you can still go ahead with the treatment. And so to finish, I think newer excimer technology is helping set new benchmarks. There's lots of procedures available today. We have a lot of choice, and we should try to offer the choice to the patient. And if we don't have a procedure which the patient really needs, we should not hesitate to either go elsewhere and operate or refer them for that procedure to someone else. It's not a great idea to keep offering what you want, what you would have or what you would like to do, and may not be to the full benefit of the patient. And Contoura offers a new option to already excellent results that we were getting with wavefront optimized treatments, and the 4 cities planning software has made a lot of help for us in the Contoura treatment plannings. So with that, I'll stop, and I'll request Dr. Shivani who's agreed to speak instead of Dr. Sri Ganesh, who's had a surgery for his shoulder and could not come to AIOS.
I think, Gaurav, by the time Shivani loads it, some interesting observations. Have you ever had a patient, Gaurav,
Yeah.
where you corrected most of the high order aberrations, but the patient is not very happy with it? Because there are some reported cases, because some patients are habituated to some of the HOAs. And I remember you and me were together at Rohit's conference once, and he shows how beautifully the human crystalline lens has adapted to those aberrations. And once you unmask the aberrations on the cornea or remove them, so the compensatory mechanism of the crystalline lens keeps standing there for a couple of months. And during these times, the patient may have issues, and contrary to what we were thinking, how the patient will have the wow effect, which was not there. So have you ever had a patient like that, Gaurav?
Yes. So there will be times when, if you do an eye trace, you will find that the internal aberrations and the corneal aberrations may either be kind of additive to each other, or they may be contrary to each other. So sometimes you'll have astigmatism on the cornea which is very high, and the opposite astigmatism on the lens, with the lenticular astigmatism is kind of in the opposite meridian. And if you try to do a topography guided treatment on the full corneal astigmatism, for example, there are times when your cornea has like 5 diopters of astigmatism, and the manifest is only 2.5.
Yeah.
So when you do the eye trace or the aberrometry and you try to segregate the corneal astigmatism from the overall astigmatism, you'll be able to take out the lenticular astigmatism. So some patients will have the lenticular astigmatism neutralizing almost half of the corneal astigmatism. Now here, if I go with a Contoura treatment without the 4 cities engine, or I just go with what Alcon was originally asking you to do, is to treat the full topographic astigmatism, you will be in a soup, because you would have corrected 5 diopters of astigmatism on the cornea. Patient needed only a manifest of 2.5, and is going to have that lenticular astigmatism now inducing the opposite astigmatism, and you'll have a very dissatisfied patient. So that's why it's very important. Every patient is not a candidate for all kinds of surgeries, and you have to really decide which surgery would. I have a few cases like that. Towards the end of the course, I can show one of those cases.
So that's exactly what I wanted to bring out during this questionnaire, was that all the HOAs are not bad. And like on my machine, we have another analyzer, it's called the ORCAM, and you can actually, I use an eye trace for a similar situation also to segregate that how much of my lenticular issues are compensating for that. So if you take away everything on the cornea, the lenticular issues will stand out more. So these are the cases where it's a good idea, before you plan any heavy, high-handed approach on the high-order aberrations, to rule out the internal and the outer.
Kamal, if you did not have an eye trace, because many people in the audience who are practicing may not have an eye trace or an OPD scan to segregate the aberrations, and you had a patient, like, there would be obviously easier ways to, without having all the devices. For example, you had a patient come up with a very high astigmatism on cornea, but much less on the manifest. Would you treat the manifest refraction, or
then
would you
in that
try
situation, if you have nothing, then probably err more towards the manifest.
Manifest, that's what I wanted to say.
Never.
Then we would rather go towards the manifest than what was on the topographic or the corneal astigmatism.
And classically, at times you'll see, you may have cataract patients who got a LASIK done, and they were at that point 6.6 whenever they got it done. But when you do their keratometry, and that is the thing which to stimulate your mind. In the keratometry, they have astigmatism, but they don't have any manifest astigmatism. So which means the laser corrected something to correct the lenticular issues also at that particular time. And now once you're supposed to take out the lens, so the question is, my optometrist used to ask me, sir, the patient has a history of being 6.6 post-LASIK, and now we're treating astigmatism. So the common sense is, I'm taking the lens out. So whatever the lens was compensating is not going to be compensated, and now it's only the cornea which is going to manifest. So then you treat the corneal astigmatism.
So let's go ahead. Dr. Shivani, I think our other speakers will suddenly come and want to speak. So Dr. Shivani is going to talk to us about expanding indications of phakic lenses and orange lights.
Yes.
So please go ahead. She's a brilliant refractive and cataract surgeon from Bombay and is doing great work. She's been winning awards.
Good afternoon, everyone. Thank you, Dr. Gaurav, sir, for considering me to fill in for this part of the course. It's been an honor to accept. Everybody, today I'll be talking about phakic IOLs and expanding their indications. So, in our practice, phakic IOLs, yes, they are also as huge a part as laser vision correction, because patients nowadays are quite aware of the refractive error that they have. Because of the advancement of technology, we have YouTube, which is explaining exactly what we do in the surgery. They don't have to wonder what is LASIK, how is it done, if I have a -1, -2, -10, what is my future ahead with this. And majorly we get patients who are young, who want to get this done around the time of their marriage or after their college education is over, when they have some free time to recuperate from the surgery. So these well-informed patients, mostly we used to have two schools of thought. One was when I started learning and when I started getting my training from my seniors, and even with Dr. Kumar, Doctor and Dr. Gaurav sir, I always had this question in my mind: if the cornea is getting compromised, why would we go for a laser vision correction, and why not ICL for everybody who has a deep AC? So the answers I would get was, obviously it is an invasive procedure. Conversion becomes difficult. It is difficult to convince the patient to undergo a surgery. There are complications which are not very commonly seen with laser as we see with phakic IOLs or ICLs. But nowadays, with the advancement of techniques and the ICL, the way it has progressed, these indications widen. We have a wider range, and there are some indications which are absolute no-no for patients who are keratoconic, patients who have had keratoplasty. Let's go ahead and see these indications. So we know what phakic IOLs are. They are artificial lenses implanted in the anterior posterior chamber of the eye in the presence of the natural crystalline lens to neutralize the refractive error. So we all know laser vision correction, going from PRK to LASIK to now like SMILE or lenticle procedures, now coming back to PRK again. But the level of comfort is high. That's why people prefer these procedures. They even come asking for specific procedures. Nowadays, with a lot of machines, they come asking for those machines as well. There's a quick recovery process. It's minimally invasive, which is what attracts them. Both eyes are done together. They're very happy with that fact that they don't have to undergo the same procedure twice all over again. And stable, predictable results. Retreatments may be hardly there with experienced people. Ability to perform bilateral treatment, no lab tests required. That's a big plus, because in today's fast times, people don't want to go for a lab test, then come back for the surgery. Minimize the number of visits to the clinic. No ordering of the lens availability, which is a factor in ICL. Except, now when all patients that come to our clinic are not normal. Some of them who have a high power are also having ectatic corneas or pre-ectatic corneas. Now again, with the advancement of the machinery that we have, even a small bit of ectasia puts us in doubt whether we should go ahead with a refractive procedure for this particular patient or should we step back. So this doubt, sometimes we always move towards safety and precaution instead of just going ahead with it. We always prefer to take an orange light in those situations rather than proceeding with a corneal procedure. Because if the patient comes back with an ectasia to us, we are again stuck. So, and these are patients who are 6'6", we are trying to give them 6'6" back. So we don't want them to come back with a complication where they'll never be 6'6", or the quality will never be great. So in risk of iatrogenic keratectasia, when excessive ablation is done or residual bed is too thin, or we see orange lights on the planner, or else we see any steepening which cannot be explained, any epithelial mapping which is irregular, and we predict excessive inflammation post-op, the quality of vision will not be that great. We should move for a phakic ICL instead. Induction of tear film abnormalities, induction of higher order aberrations. So tear film abnormality is extremely common in cities as well as everywhere these days because of dryness. It's an epidemic, pandemic sort of. Higher order aberrations leading to poor contrast sensitivity, limitation of night vision, especially high cylindrical powers. Although number of years these incidences are dropping, number of years the laser correction of higher diopter has dropped as we understand healing of cornea and corneal response to laser correction. Advantages of ICLs in these conditions are preservation of architecture of the cornea, predictable refractive results. In a long practice as well, we'll see cases where the vaulting has become unusually high and it's an unpredictable error. The white to white is normal, everything, gonioscopy, you did a UBM as well, but suddenly there's a high vault that we see which can't be explained. There has been an error somewhere. But these complications, even in high volume ICL practices, as one extremely informative course that every time I attend in all conferences by Dr. Kamal Kapoor, he's the one who inspired me to do more. So in that as well, these surprises are there, but they're rare in hands who have already done many ICLs. So preservation of accommodation, reversible and adjustable, no costly equipment required. So no LASIK unit of M2 unit necessary, not everyone can afford it. Shorter learning curve while performing. Indications can be any refractive error which is unsuitable for laser vision correction, as I said. Myopia beyond 9, now even refractive errors as low as -4 diopter can be corrected. Corneal thickness less than 430 and residual bed which is likely to be compromised after laser vision correction. So we went from Benedetto to Bekoff to now artisan lenses. We have options of anterior and posterior and iris fixated. Of course, we go for posterior most commonly. Older ones had variety of complications like IOP spikes, pigment dispersion, cataract. Not saying it never happens now, but the incidence is much, much less. Eliminates the need for a peripheral PI nowadays because of the central hole outflow system. Now powers range from -2 diopters to -20 diopters. Toric correction up to 6 diopters. Advantages of smart torics are available, where you just implant them at 180 and there is no rotation required, no alignment required, so smart torics are now available. Extremely thin with an optic center measuring 50 microns, haptic 500 microns, so this makes it really easy for the placement, as well as less chances of vaulting errors, less chances of rubbing against the structures and causing glaucoma or cataract. Overall diameter is also a wide variety. Sizing depends on white-to-white measurements. We have excellent modalities and online methods available to measure it yourself. You can even ask the company to do it for you. It's extremely easy and lucid these days, and results are quite predictable and meticulous. ACD, Schaffer grade 2 or above, our cutoff at our center is 2.8, very rare 2.75, but 2.70 I've seen people do it. Material, we all know it's hydrophilic collagen polymer. So the prerequisites, we would say more than 21 years because studies say so. We've done younger patients. Stable refractive error, adequate ACD is required. Good endothelial cell count is required. White to white is required, which should be normal. And no ocular pathology like pre-existing iritis, cataract, glaucoma, retinal pathologies. As with any other case of any other surgery, pre-existing pathologies will compromise the result of your surgery, whether it is a laser surgery, whether it is cataract surgery, whether it is ICL. So that is something that is common for every surgery. And now broadened indications, range of refractive errors corrected. So corneal thickness is not compromised even with a high range refractive error. Astigmatism can be taken care of without compromising the night vision of the patient. Customized toric power is available, and unilateral high refractive errors like anisometropia can be easily corrected. Patient who has keratoconus, it's a very common disease. We all know the nitty-gritties of keratoconus. Stable keratoconus for 2 years we can treat. Safe and predictable, no tissue loss, so we are not worried about that. In unstable keratoconus, where we know that the cone is not central, we can stabilize the cone with a C3 with an intact segment, intracorneal ring segment. We can do that. Once it is central, we can do an ICL. We have done this. It's worked beautifully in the past. Sorry, I'll take a few more minutes. So combination procedure of intracorneal ring segment, C3R and phakic IOL is safe. For progressive KC, we can combine it with a DALC or procedure as well. Boon for contact lens intolerant patients. Many such patients exist who get allergic symptoms. GPC, which is extremely intolerable for the patient. Myopic astigmatism can be treated in those cases. Reversible and adjustable for future refinements for toric alignment. Post-keratoplasty, clear corneal graft with high astigmatism or spherical error. We predict this in all keratoplasty patients. Good endothelial cell count and deep ACD is required. Posterior PIOLs are preferred in such cases. Residual refractive error correction. Piggyback IOL for pseudophakic eyes, the easiest thing to do. Symptomatic cases can be treated with this method. Use of piggyback IOLs with adequate ACD, of course. Presbyopia, not much, I don't have much experience in this to be honest, but there are multifocal diffractive IOLs present. Pediatric PIOLs are also available. Now, Indian versus imported, it's about the cost because I've seen results which are quite comparable. There are 2.8 millimeter incision compatible injectors. Comparable visual outcomes. Standby IOL is provided. Designed with a 350 micron central drainage hole. No iridectomy needed. So, in conclusion, I would just like to say that broadening indications for phakic IOLs, choose your patient wisely. If the patient is not willing for an invasive procedure, those patients have to be explained the pros and cons of the residual refractive error. Some patients are comfortable. I have seen that in my limited practice, I have seen that it is important to know what the patient's requirement is. Some patients feel that if more than 70% of their glass power can be deducted, if they're wearing a -10, -12, -15, then if they're left with a residual of say -3, they don't mind wearing glasses sometimes. Very few. Some of them want a complete removal of the glasses because they've lived too long with those thick glasses. Getting up in the morning and hunting for those glasses being the first thing is a really troublesome thing for them. So it is, I think, a good option to consider to switch to phakic IOL, ICLs for that case. And they do come asking for ICLs these days because, as I said, patients are quite aware of what their condition is, and of course they have taken opinions at many places. So they come asking for ICLs. The cost factor is there, but I think we have an option of Indian versus imported as well. We can explore that, and patient counseling is extremely important. Having told them that they can have complications, whereas hearing from LASIK that it is a daycare procedure, you can go back, and the recovery time is a little easier on them and complications are a little lesser. They do tend to move towards why not LASIK, but if the safety factor is high, I think we should go for the safer procedure. Thank you.
Thanks, Dr. Shivani. That was a very nice, comprehensive information. I have a quick question, Dr. Chitra. Since your center does a lot of phakic lenses, what's your threshold now? Has it changed over the years? Like, at what part do you start thinking of moving from a laser correction or a corneal-based procedures to a phakic? And first, we'll take both of you.
So in my practice, beyond 6.5 or 7, I hesitate to do any corneal procedure for the simple reason, I have my own reasons of, I feel it may affect the contrast of the patient. Why should I unnecessarily change the biomechanics of the cornea? So my cutoff would be upper limit is 7. Only if the patient insists and the cornea still has a reasonable tissue there, I would approach. Otherwise, I just fold my hands and say bye to them, and I said you can go and get operated somewhere else. But to my surprise, there are some patients, some surgeons known to me who are probably operating at 9, 10, 11 also. And they are doing it, which is fine. My cutoff is around 6.5, 7 is tops.
Dr. Chitra, what's your cutoff? Like, at what part does your center start offering phakic lens?
Nowadays, irrespective of the corneal thickness beyond -8, we have shifted to doing phakic IOLs. And because we do believe that there is some amount of aberrations which are caused on the cornea when you're treating higher parts. And if how low would we go? Supposing a person has a -3 and has a 438 or 440 cornea and all, I would do a phakic IOL for those patients.
Now that said, ma'am, I get your point, but there are other centers which are which don't own an examer and offer ICL or phakic lens as the only option. Now, is that a great idea?
See, it's an intraocular procedure, and like just like phaco, there is a learning curve to it. There's a lesser of a learning curve to a laser refractive procedure because if you have the topography and you understand the basic dictums, it's easier to do. And these are very young eyes, so incidentally, your incision goes and does a lunge touch, and there is some miscalculation, and there could be anything. Even an endophthalmitis could rarely occur. So unless it is if there is an alternative, like a laser vision correction for simpler parts, we need not do it. Now, I would not motivate a patient sitting in front of me with a -3 and tell her, get phakic IOL, phakic IOL. No, I won't do that. If she's crazy about doing, all her relatives have got it done, and her cornea thickness is not going to allow, then I would suggest phakic IOL, and I would be very strict that anterior chamber depth is 2.8 millimeters or more, and not otherwise.
Thank you. So, Kamal, you had a quick thing, and then we'll move on because we are running out of time now.
Shivani, you just mentioned everything. I think 2 points I'd like to mention here is always do measure the angle too. Because with my large experience of pupil size, angle, and the clear lens rise. These 3 things you probably skip because they play an important role. I was just in another session doing an IC on phakic lenses, and Sanjay Chaudhary presented 4 cases where he said that the vault was 750, 800 and the lens kept rotating. So I told him I've got 9 such cases. On retrospective, I found their CLR was minus, which means the clearance, the lens, crystalline lens was practically vaulted backwards. So in these situations, so you should have a CLR angle measurement. In my hands, I've seen 15 to 18 degrees of angle shallowing when you use a phakic lens. So if you have a pre-surgery angle of 30, you should be a little careful.
And even if you should not think that if it is 2.7, I'll do an YAG PI and I can place the lens. It does not help at all. And in case you have a patient with a high vault, it has happened in spite of the fact that everything was fine, then you should actually follow up these patients, do a serial gonioscopy and then take a call. If things are changing, you may have to remove the lens too.
The saving grace is that some patients over 5 to 7 months will keep losing the vault.
Yes.
They tend to make their place on the zonules,
Yes.
but you cannot bet on it all the time.
But Kamal, I also wanted to point out here that literature says that 20 microns of vault is lost per annum, and over 10 to 15 years you may actually end up using between 100 to 200 microns easily. So if you're leaving behind a very low vault, that's why I'm not going to offer phakic lenses as my first choice. I would still do laser correction as my first choice, and where laser correction is not indicated, because laser correction has stood the test of time over 25, 30 years, and we still have patients doing great. So I would only do phakic lens when there was an indication and not just offering it as my only procedure.
Yeah.
So I think we should quickly move on. Shivani, you can come sit with us.
Thank you.
And we have the young and dynamic Dr. Raghav, who's going to talk to us about KLX.
You
That's
see
a
what
new-
he has done.
Thank you, Gaurav sir, for this opportunity. But first, before everything, I want to wish Gaurav sir a very happy birthday.
Thank you.
Thank you for conducting this course on your birthday. So today I will be speaking about KLX. Now, what is KLX? So KLX is the term that is collectively now being used by the Refractive Society, which includes all the lenticle procedures. Till now we had a monopoly with just SMILE being there, but now we do have 4 commercially visible procedures. So the combined term that we are now going to use and that is accepted internationally is KLX. So I will be talking about what is KLX and when do we offer KLX and when can we add an extra to the KLX procedures. So we have gone from conventional LASIK with the microkeratomes to a blade LASIK, then the blade-free LASIK, and then to a no flap or a KLX surgery where it's a single step procedure with a single femtosecond laser making a lenticule in the stroma and which can easily be removed through a very small incision. So KLX is a revolutionary new method for laser vision correction. It has a combination of a precise refractive femtosecond laser and lenticule extraction. So it is flapless, all femto and a single step procedure. So like in a with flaps, we of course require 2 machines, either a blade or a laser and an excimer. But now with the lenticle procedure, you just require 1 laser, and also the advantage it is not affected by the humidity, the temperature, because there is no excimer involved. That is also an advantage. So this is how basically a lenticule is shaped. There are 4 cuts, that is the posterior cut, the anterior cut and the side cuts. In this image you do see that the first one, that is the green, is the posterior cut. This is a lenticle that is plano-convex. What I mean by that is that if you look at the undersurface, the green surface, that is plane, that is flat, while the upper surface, the blue one, that is a curved, that is a plano-convex lenticule. But now with the Elita, that is a silk surgery we have by Johnson & Johnson, we have a proprietary biconvex lenticule. That is both the surfaces of the lenticule are going to be convex. Just like you have a high definition camera, the lenses are biconvex, they cannot be plano-convex. Similarly, we are making a biconvex lenticule in the cornea, which is hence removed. So this is just a procedure. On the left we have the Elita, on the right we have the Visumax. So you can see that in the Elita, so in the Elita on the left, once you dock, there is a different laser pattern. You do have a cyclotorsion compensation and you can center the lenticule. Once it is docked, that is the advantage of the newer femtosecond lasers. The Visumax did not have that. Of course, because we are also thinking of giving the patient 6x6 and 6x5, so we have to treat this astigmatism as well. So once the laser is fired, then on the right, I am going to show you the procedure, that is the Visumax. We have the posterior cut and the anterior cut. This is the side cut now happening. You see the edge. And And once the laser fired, the surgery is pretty simple. You just open up the incision. The critical part is finding the anterior and the posterior plane. Once you find the anterior plane, take your dissector inside, and with the increased surgeon experience, this becomes pretty easy, and within a matter of minutes, the lenticule can be out. Once the anterior plane is dissected well, you go beneath the lenticule into the posterior edge and dissect it well, and the lenticule can easily be removed. So in eczema, of course, you had some challenges with the humidity and temperature, like I mentioned, and also there could be a peripheral loss of energy compared to the central, and also the chance the jury is out whether the chances of keratosis are higher in a lenticule or not. But yes, in calyx, the chances are lower given the literature, but yes, no one does like to report the ectasias, but yes, what is reported till now, there are lesser ectasias with the calyx compared to an eczema. Confocal microscopy, calyx, at the end of 1 month, you can see how the nerves are being regenerated. There has been extensive work done by Ryan Nethrale with Dr. Shetty that compare the regeneration of nerves at 1 month. Sensitivity also it regains very well with the calyx. We do know that yes, the anterior stroma has the most amount of biomechanical strength in the cornea, and what we are doing is we are essentially making the lenticule in the mid and the posterior stroma, and we are leaving part of the anterior stroma untouched, which is not the case with the PRK and a LASIK. So yes, we can say that there can be better biomechanical superiority, which we can see with our hysteresis and the Corvus. So no flaps, of course, no, there are no flap-related complications, no flap wrinkles, lesser chances of ingrowth. I won't say no chances because we have had ingrowths in our lenticle cases also. No microstriae, and DLK, of course, is lesser. So calyx versus LASIK, there are many advantages. Single step, single laser, no chance of any aberrations with the weather or the humidity or temperature. Lesser post-op inflammation, lesser cut, smaller cut, so lesser chance of infection, and no chance of flap-related complications. So now that we know that yes, calyx is here to stay, and there are multiple platforms that are trying to stay in the market. Now, once we get a patient to go and agree for a calyx, should we not, or should we add an additive procedure, that is an extra procedure? What is an extra? An extra is a LASIK removal or a lenticule procedure combined with the cross-linking. So on one hand, we are doing a weakening procedure, and the secondly, now we're talking about combining an extra to make the weakened cornea stronger. So now, is it actually required? Yes, the jury is out. It will always be a matter of discussion whether we do need it or not. But yes, we know that there is a 14 to 33% corneal weakening due to the flap creation itself. We're not talking about the eczema. This is just the flap creation because the Bowman, yes, does get irritated. There can be, if we do just the laser vision correction, there can be regression and iatrogenic ectasia. So what are the cases when we do expect an ectasia? According to the Randleman's ectasia score, yes, preoperative high myopia or hyperopia, thin corneas, the abdominal topographies of the formed frustes, the eye rubbing, pregnancy. There are centers that are not doing tomography, they are still doing topography, and we get those complications with us. And certain with hormonal balances of pregnancy, we know, yes, that is an established fact that there can be chances of ectasia after pregnancy. So on the left, you see a cornea that is not cross-linked, and on the right, you see a cornea that is cross-linked. So yes, there are visible changes immediately. Our group has also discussed about a lenticule addition cross-linking, where we use a lenticule to do cross-linking. So we can see the lenticule gets taut immediately after cross-linking. So yes, theoretically, the cornea does get stronger. So it reduces the chances of regression and also risk of corneal ectasia. But do we actually need that extra procedure? Apart from the biomechanical advantage, simultaneous cross-linking may also lead to less epithelial thickness increase, which is also a cause of regression. So yes, the extra, I'm talking about the points that are in favor of extra right now, that we can have a decreased chance of ectasia and we can have a decreased chance of regression also. But the concerns are, of course, whether it is safe, what about refractive effect, because we are talking about patients who had a preoperative 6x6. If we do, and we know the complication of a high power which we treat by an eczema, the chances of haze are there. And also if we do another procedure which is a cross-linking, which also has a chance of haze, we can have a double haze. So that is also one issue that we are facing. And long-term outcomes, do we have progressive flattening with the cross-linking? That could lead to a hyperopic shift. So who's a candidate? Dr. Shrital Babrar and Dr. Sri Ganesh have described very beautifully who is a candidate who should opt in for an extra procedure. You see that this is of course age, younger age, high myopia, thinnest pachymetry, the residual bed less than 275. Of course, if we do have a biomechanical machine, the TBI, and also any patient who have 2 or more of these factors should go in for an extra procedure. So Smile Extra, if we do a Smile Extra or a KLX Extra, we do use the dye which is the thinner dye that does not have dextran. We fill the pocket with the dye. Now another issue is that all the surgeons out here will have a different protocol. No two surgeons will have a different protocol. So that will have a same protocol. That is one issue. So we do take 0.25% riboflavin and inject it in the surface for 60 seconds. I'll just show you a quick video. So this is once we do a KLX and the lenticule is removed. Once it is removed, we fill the dye is injected for 60 seconds and then we cross-link the cornea for 90 seconds. We use half the energy required for a normal cornea because this is a already weakened cornea. We use only 2.7 millijoules. And of course, very important is that we have to irrigate the interface, and once it is irrigated, then we show the ultraviolet light. So these are results that have shown some improvement of vision and also no chance of ectasia for long term. On the right, you can see Smile Extra may be equally effective as compared to just a Smile. So now, is Smile absolutely necessary? Absolutely necessary. So of course, there are no specific indications. The jury is out whether we go for an extra procedure or we switch to a phakic procedure, phakic lens procedure. There is a vague definition of a borderline cornea. There is no guidelines. There are papers, but yes, we have to follow it as a very case-based approach. Subjective decision, no consensus of safety, and not a lot of data on hyperopic extras. So the protocol.
Raghav, I think we should.
Yes, I'll just
conclude
give me a minute,
because
sir. I'll just wrap up. So I just want to ask a couple of questions. That is there a need for an extra procedure? Why is there no single consensus, and how should the refractive society find one? Also, why not perform in all cases? And does stiffening help in the normal cornea or the pathological cornea? And should we go for a phakic IOL? And lastly, would you get it done for yourself? Thank you.
Thanks, Raghav.
We could discuss it later.
Yeah, we'll do the
And I also
discussions
finish
later
my
because there are a
talk.
lot of
Yeah.
things.
Yeah.
So we'll request Dr. Kumar, thank you for the nice talk, Raghav. That throws open lots of questions. Dr. Kumar is going to speak on something very difficult because he does lenticules, he does everything. He does, topo-guided treatments, and he's been a pioneer. But I gave him a topic which was very relevant because there are many practitioners who would still want to do microkeratome or femto-guided femto-LASIK, and we can't be looking down upon them. So they are still a very relevant part. So
Pooja is laughing at me. My topic is over now. Okay, we'll go fast because we have to go. Pooja also has to go to the other hall. I also have to go. So is there a role of microkeratome in today's era? We all have the excimer, and some of us have the lenticule as well as the femtoflap procedure. So is there any role? And I think I will answer it fairly. We have gone through a long way. I've been doing LASIK since 1999. I had the I had the microkeratome from Moria, the M2, the M1, the manual, and I've done it all. So is there any advantage? Yes, one choice is availability. Today's world is less. About 10 years back, we had 5 companies making microkeratome, and today only one company has survived, and that's Moria. So you don't have multiple choices of buying multiple microkeratomes, but it's quite affordable. So it's much cheaper than anything else. Very good results with test of time. It is stable. It is consistent. Another big advantage is portable. You can't carry, yes, now the new femto machine can be carried around, which is a Z8, but this one, you can easily carry it around and use it in another LASIK room. It's easy to use. Another big advantage is that the CMC is very less. So CMC is comprehensive contract. You know that if you have an excimer or you have a big femto laser, the CMC is very, very high, so it's a bigger headache. And proven that the test of time, the flap complications are much less today. Yes, you read everything in theory, buttonhole, epithelial ingrowth, stria, etc. It's not that it won't happen, but yes, the incidence with the new microkeratomes is much lower. I agree that there is some incidence of dry eyes, but there is something different, that is a flap to hinge ratio, and there is a learning curve. So this is a blade LASIK, which you can see the microkeratome. You can have a nasal flap, you can have a superior flap, you can have hinge any position you want. So this is the Schwind-Reazo pendular microkeratome. Just put in a little bit of saline. Once you've done that, go ahead and put on the pendula. Very, very easy to use. I'm making a 90 micron flap. I also have an online pachymeter on the examer, which will actually tell you what's the flap thickness. And you can see such a smooth bed. I mean, there's no doubt about it. Of course, you have to make sure that you don't keep using the same blade again and again. I normally use one blade for 2 eyes, and that does extremely very well. So this is as far as the this thing is concerned. Again comes to history. So how did laser surgery actually start? It started with surface, there was PRK, then came blade LASIK, then came bladeless LASIK, and again we are back to surface, and then came the lenticule. So this is the evolution that has happened in refractive surgery over the number of years, and studies on dry eyes and healing process has shown that yes, it does heal much faster than surface. Surface does take a little longer to heal compared to the flap LASIK with the microkeratome. And also the confocal photography of the subnormal, the anatomical layer of the stromal fiber arrangement, which is a new technology which Dr. Rohit is actually going to make as a technology or as a machine, and this will help us to understand ectasia much better. So in today's world, we have options like surface, blade, bladeless, flapless, ICL, etc. It's not that you can chuck the microkeratome out. There are big advantages in that. So some centers does only surface in Europe with lenticule. They do not have the microkeratome at all. And some do surface and lenticule only, but no blade at all. And some doctors do everything. It all depends what you can do, but believe you me, it's not that microkeratome does not give results. There are lots of advantages, like you can't do hyperopia in lenticule. You can't do a very high plus with minus on a lenticule. You can't do a wavefront guided or a topo guided lenticule extraction. So these are today's limitation. Of course, it will change over time. So there's also no doubt that surface treatments have improved over the number of years. Now we have something called as a smart pulse. Each one has their own technology where the epithelium itself is removed with the help of the examer laser. So you don't need to scrape it manually. You don't need to use diluted alcohol anymore. But of course, femto laser is safer, more reproducible. So if you have a small white to white, you would prefer to use a femto. You should not use a microkeratome. 90 micron flaps are today possible. The flap to hinge ratio is one thing which is very, very important, which is very consistent in a femto, but you have to be careful in the microkeratome. What I mean is the diameter of the flap to the length of the hinge is always consistent in the femto, but not consistent in the blade. So that's one care you have to take as far as the blade goes. You can move the hinge in any direction. Side hinge angulation can also be controlled. So lenticle extraction further has changed the game, and of course it comes with a cost, and it's much more expensive. So I'll just show the flap creation on the Z4 which I had before. So this is the flap that is created on the femto. Now you can see that the diameter of the flap to the hinge length is consistent in each and every case. So this is as smooth as just going underneath and extracting. You can see a very smooth surface. And what I meant was the diameter of the whole flap to the hinge of the length of the hinge is consistent in femto, not consistent in microkeratome. So that care you have to take if you have a microkeratome. This is just an image of the interface that you can see post-op when you dilate the pupil, and it sees very, very clear. So the answer today, I think there is a room for microkeratome. I don't think we should chuck it completely. Yes, if you have access to a femto, good. If you can do lenticule, very good. But and you do surface, still better. But it's not that microkeratome should be chucked completely. Thank you for your attention.
Thank you, Dr. Kumar, for very nicely doing that. And yes, there will be always some indications for microkeratome LASIK as well. And also low-cost centers, I've seen that, sometimes in the peripheries where, centers which may not be able to afford a femtosecond laser, the microkeratome will still be very, very economical thing. And also for patients who can't afford surgery of, very expensive refractive surgery, I think we should keep this in the armamentarium for that. I'll now invite our dynamic, past chairman of the ARC and also TNOA incoming president, am I right? So, okay. Okay, the election is still due, sorry. So Dr. Chitra Ramamurthy, who's a dear friend and senior, she's going to be talking on when to offer PRK extra, and after that we have a talk on PRK itself by Dr. Pooja Khamar from Narayan Netralaya to wrap it up. So please go ahead, Dr. Chitra.
So first and foremost, I'll start my talk saying, very happy birthday, Gaurav. That's the kind of friend he is, that he wishes me a post even before I won the elections. So I know if I have such friends, sky is the limit I would reach. So a very happy birthday. So my due in the next few minutes is to when to offer PRK extra over others, but I'm going to give a summary of everything so that we can decide together what we want. We all know now that extra procedure means combining laser vision correction with cross-linking. There has been extensive literature research which has been done. There have been only encouraging facts which have come forward. There has been nothing very drastic or daring about it. But what comes through is that you need to refine protocols, because there are different people are using different protocols, and it is important that when you accept something as a way forward, probably, it needs to be more stable and consistent. As was discussed by all my previous speakers, whenever it's a very high refractive error or a thin cornea or a borderline topography or allergic manifestations like grubbing or keratoconus history in the family or pregnancy, these are times when you stop and wonder whether you can do a laser vision correction on the cornea of these patients. It might appear that you will be able to leave a 300 micron residual bed for these eyes, but then there is a certain doubt about some minuscule nuance in the topography which is not appearing okay. We also know that a feature of biomechanical weakening of the cornea can express as ectasia, could also be regression, which is actually a different remodeling of the cornea, which is not planned for. So for this, there were different cross-linking procedures which have come forward along with each of these cornea-based procedures. It is just that one thing which has come across is they are safe, they are efficacious. There is the refractive accuracy, there's no change in refractive accuracy, but what is the amount of cross-linking? The favorable points is ectasia, the actual percentage now with the kind of understanding we have of topographies is just 0.02 to 0.6. Genetic expressions have indicated that there is also a low expression of lysyl oxidase in some of these eyes, which could contribute to either ectasia or regression. So what are the actual concerns? Why are we discussing whether to combine cross-linking is? We all know with the regular cross-linking there's some flattening, there is compactness of the lamellae, which is what we believe gives stiffness to the cornea. There is could be a mild haze, there could be a refractive impact for some of these eyes. But then, none of these happen if you use a low energy fluence, and only thing, the biomechanical tool to understand whether the cornea became biomechanically strong is still dubious. Like all that we have with us is Aura and Corvis, and we are not 100% clear whether the Corvis is right in all times. So based on the different published data, we know for PRK, you debride the epithelium, you do your ablation, and instead of 0.1, you would use 0.22 to 0.25 riboflavin you would use. In our setup, we would apply these drops for 90-second soak and then irradiate so that you have a 2.7 millijoules. That is, it would be 30 milliwatts for 90 seconds again. But there are some people who have used 5.42. Finally, anyway, majority do stick to 30 to 45 milliwatts and a contact lens is placed. Otherwise, the follow-up is similar. Now, when it comes to LASIK extra, you actually fold up the flap and then do cross-linking on the stromal bed, because the flap, if it's exposed to the riboflavin, there could be flap shrinkage can occur, there could be striae on the flap, so you need to keep the flap folded and protected. Again, the energy protocol should be largely 30 milliwatts or 90 seconds with about 2.7 millijoules, but there is, again, variables in the different studies and there's no consensus. For SMILE extra, pocket of crosslink, riboflavin placed in the pocket, but the irradiation is transepithelial, which has to be kept in mind. So then, ectasia, the follow-up has been minimal, but for regression, what we understand is by doing cross-linking, it definitely, there is better biomechanical strength, there's reduced corneal epithelial remodeling. There have been 10 to 12 papers on myopia, 3 papers on hyperopia, and some more on extra, which all have shown that there has been no refractive impact. The very encouraging point was in the hyperopia study, there were eyes which were followed up for 3 years. It was seen that those eyes which underwent hyperopic LASIK with cross-linking, they had more stable refraction with no regression which was happening. This also was encouraging in SMILE extra, though there were a few who have used very high energy as if they were doing for a regular keratoconus eyes. But it is important for us to stop and understand that we do not use the conventional method, but we use accelerated cross-linking because the amount of flattening and haze we know is very minuscule in that. We know that LASIK flap is not going to contribute to the biomechanical strength, so you wonder how effective doing LASIK extra with LASIK is. With the smile, the epithelium is intact. Even though you have left riboflavin in the pocket, the cross-linking is through the epithelium and there is less of oxygen. So then you also understand that there are many people who say just doing PRK alone is also enough because there is some inflammation and there is tightening of the stromal lamellae. So do we need to combine a PRK extra with PRK? But logically, whatever studies have come up says that PRK seems to fare better than smile than LASIK. So if you're doing cross-linking, it makes best sense to do PRK extra for these cases. And then, of course, there is no adjustment in nomograms. Mitomycin C has to be used to prevent the haze because of the migratory fibroblasts. There is no flap linkage. And because riboflavin diffusion occurs, in these LASIK extra flaps, the flap adherence is better. There are hardly any cases of keratitis, DLK, or keratopathy. So, but the final thing which remains is, when you talk of biomechanics, you don't want tissue subtraction to weaken the cornea. LASIK extra, there's vertical cuts, which is not good. Smile extra, there's delamination cut, but even that does bring down hysteresis. With PRK, you're disrupting the Bowman, which is contributing maximal to the tensile strength. So then you wonder, in those very borderline corneas, do we do a PRK extra at all, or do we go ahead and do a phakic IOL for these patients? But when it comes to regression management, every study has been very encouraging that it definitely seems to address the epithelial hyperplasia. So then, having seen it all, there have been different studies, 6 months, 1 year, 2 years. Nowhere there was a loss of BCVA. No, there was no increase in flattening. There was, in fact, gain in lines in some eyes. There was no endothelial haze. Some of them had temporary haze. They have used abnormal energy protocols. So what you can understand, this was our study where we have compared 118 eyes with 109 eyes. And what came through when we compared PRK extra with PRK was that they continued, both the studies, the results were stable. There was stability in the refraction. The mean K was also comparable. So one thing definitely comes across, that PRK extra is not going to be do harm. And possibly a role of MMC should be there when we're doing PRK extra. Thank you very much.
Thank you, Chitra ma'am, for very comprehensively covering the topic. It's a very important topic. Thank you so much. Please come. We'll have a small discussion, and I'm going to invite Dr. Pooja Kamar, who's come out from Rangachari Award judging, I think, to give this talk. Thank you so much. And she's talking on something which they have done tremendous amount of work at. She's been pioneering lots of new techniques on PRK at Narayan Nethralaya. So please, we'll be happy to hear you.
Thank you, sir.
And we got the hall 5 minutes late, so we'll try to finish it off as fast as we can.
Thank you, and I'm extremely grateful to you for making me a part of this IC. I think I'll stick to the important slides which have not been covered. So we all know by now that PRK is a procedure of choice when you are dealing with a thin or extremely steep or a flat cornea, or your corneal thickness is a borderline between 475 to 500 microns, or sometimes if your RSBs are going below 300, I think and your refractive error is less than 6 diopters. Or if the patients are into contact sports or into armed forces, or any of such procedures where they can get hurt, or trekking, one of the procedures to go for is the PRK procedures. Now, PRK has transitioned a lot over time. It started with a manual removal of epithelium, then it went to PTK along with PRK, which is so-called trans-PRK, a 2-step trans-PRK, then came the 1-step trans-PRK, and now we have all different technologies which offer you a 1-step trans-PRK. So now, what is the difference between LASIK and PRK? Grossly, if you see, is one of the advantages in PRK, you do not have any flap-related complications. We do have CLEX, but it also has its different learning curves. But PRK, there are no flap-related complications, or it's more suitable for patients with thin corneas and an active lifestyle. And the most important part is the corneal nerve preservation in PRK procedure is much better than that of LASIK or SMILE. So I think that is one of the reasons, when patients have ocular surface diseases, or if they have dry eyes, trans-PRK could be looked at one of the factors. Now, I'm going to be talking from Schwinn perspective, but what I'm going to highlight here is very important. Now, when you are doing a trans-PRK is nothing but the laser removes your epithelium followed by power correction. Epithelial map is one of the very, very, very important factors, because if you're doing laser is going to remove the epithelium, you can't just go ahead and enter 55, because your patients might have a center of 55 and a periphery of 60, or they have a epithelial thickness of 65. And these are the patients who can land up into an overcorrection or an undercorrection, and you probably might not know what it is. So if you are doing a trans PRK, always try to look at epithelial map. And if you have an irregular epithelium to begin with, of course treat the ocular surface, but go ahead with a trans PRK because the post-op remodeling of epithelium in this trans PRK is much better. You can use drugs like cyclosporins and sodium hyaluronate that will give you a good epithelial remodeling, which will give a good quantity and quality of vision. And if you see different technologies which gives you trans PRK, I think there is not much of a difference, except there is a faster wound epithelial healing in smart site, which is from Schwind compared to that of Streamlight, but otherwise there is not much of a difference. Now the second choice of procedure, why I like PRK is, if you see, this is relatively a healthy looking topography and a thickness of 563. So anybody would be tempted to go ahead and do a refract like a LASIK or a SMILE for these patients. But if you look at the epithelial map again for this patient has a donut shape of an epithelium. That is nothing but an early sign of evolving ectasia. And Professor Dan Reinstein has done extensive work on O sign of or a donut sign of epithelium. So we do know that even if today the patient doesn't have ectasia, probably tomorrow he or she may develop. So always, to be on the safer side, you can choose a trans PRK procedure for this patient. PRK again is, a lot of times patients have come back with regression post LASIK done elsewhere. You do not know. ASOCTs are not able to pick up if the flap is even or uneven. Then again, if it's a very thin flap, there is always a risk of lifting up the flap because it can lead to a flap tear. So PRK after LASIK also can be done, and it's a very good procedure because it is a procedure which will lead to lesser dry eye, no risk of epithelial ingrowth, no destabilization or weakening of the cornea, and you can use mitomycin C as ma'am suggested. You can also use PRK after PKP or RK, which has been done for a recorrection, because that is the procedure of choice which you would want for this patient. And PRK can also be done for patients after cataract surgery if you have a refractive surprise. Now a lot of patients do say that, if I do a PRK, the quality of vision is not very good. The answer is not that. If you have taken care of your ocular surface very well, and if your machine is well calibrated, there is a very, very, very minimal risk of refractive surprise post-surgery, and the quality of vision maintained is also very good compared to that of LASIK and SMILE, and this has been published in JRS. And the risk of haze, people say yes, we are scared of developing haze. So this is a very nice algorithm which talks about, if you are doing a trans PRK, what all signs you should look at, which will predict that whether your patient is going to develop haze or not. And if you think the patient is going to develop haze, you can pre-treat the patient. And after surgery also, you can use sodium hyaluronate and cyclosporin based drops for reducing haze. And regarding the pain, which is the other demon, you can use a cold chilled BSS to wash your ocular surface after the PRK procedure, and also use a cold BCL and which reduces the pain much effectively. So if you see PRK, yes, is an advanced surface ablation procedure, and it is, I think it would be a go-to procedure because, as Chitra ma'am mentioned, it induces lesser biomechanical changes in the cornea. It is also go-to procedure for post-recorrection patients. If you have epithelial abnormalities, you know that you want to treat the patient with a trans PRK, and also PRK is associated with very, very, very minimal risk of ectasias post-refractive surgery. So I think that would be my go-to procedure compared to others if I have an option for it. Thank you.
Thank you, Pooja. That was wonderful. And Kamal is sitting next to me, and he's been prompting me again and again and saying that अगर हेज का डर निकल जाए तो मैं सारे पीआरके ही करा करूँ.
सर साइक्लोस्पोरिन यूज करना शुरू कर दो.
Right. So I was going to ask you.
यूज किया है, but जब आनी है ना तो आनी है.
वो तो आनी है सर, बट वो तो स्माइल में भी एक्टेजिया होना है, रिग्रेशन होना है, and so I think every procedure has its disadvantages.
So I wanted to ask you, what percentage of patients in your practice, like you're doing large numbers of PRKs, right? What percentage of patients eventually go on to get haze after all that we do, like all the measures that we make? Suppose you're doing like 1,000 or 2,000 procedures per annum. How many do you think? Because haze will present within the first 6 months to a year most often if it has to.
I think the incidence of haze in our practice with doing all this, there is an incidence, as sir said, you can't say that it's not there, but it would be probably 1 in 500 patients, so which is extremely low.
Exactly.
And if you keep your patients on follow-up, and I have had patients who have come back with haze at 1 month or 3 months. We start them on tacrolimus right away. So it significantly reduces. And the second most important thing which works very well is vitamin D. So initially I never used to believe in vitamin D treating haze, but I think these two factors have helped a lot. So
Absolutely. So I think I was telling him the same things, and incidence is actually very low. It's not very significant. And Kamal, you have to go learn from Pooja how to
no,
do
no,
PRKs.
no, no, no. I have to come to it.
And
Biggest concern is that I've been burnt very badly. There was a girl, young girl, going for. I was sharing the stories, 2 or 3 stories, and it was so devastating for me as a surgeon. She went into depression. She couldn't clear a medical for the job she was going in for, and there was nothing I could do for her because everything I followed, and still it happened.
So that is one of the reasons, again, that is a genetic factor which you
Yes.
cannot factor. So above everything, we do have to remember that there is going to be a genetic factor which even if you do recorrection, they may develop.
even Dr. Chitra Center does high volume PRK, I know that. So what's your take on haze, ma'am? Quickly, if you can tell
No,
us.
but everybody needs to believe me that we just not had haze. Those patients, one odd patient who has had haze came after a long time, they had stopped steroid drops. We put them on topical steroid drops in a tapering regime for 3 months. We keep them on vitamin C also and artificial tears for a long duration. And we use mitomycin on the surgical table. So this is all that we do. And it's transepithelial PRK, we don't do mechanical debridement or alcohol. So otherwise, we have not. But then, we don't ever do more than -6. So that is one thing which is limiting, which is also one reason. Only in higher paths you get haze. So then you should use the exposure for every 1 diopter, 10 seconds of
That's the
mitomycin has to be
LVP
used.
protocol is 1
LVP
diopter for every diopter, 10
every
I
seconds.
just have one point to add,
Yeah.
if I may. So again, trans PRK is a very good procedure, but it is not always like, because now we have LASIK, SMILE, ICLs. It's not the first line of management.
Yes.
But wherever you do not have an option,
Then-
trans PRK
Yes.
works very well.
Yes.
Because it's not right to reject a patient for wrong
Yes,
reasons.
yes,
So I think it's always a backup option.
Backup option.
Okay,
yes.
final question because this course, yes, Raghav?
So do we ask our patients for UV protection?
That
Yes,
is the
coolers.
key. That is the most important thing. In
100%
fact,
cooling
on-
glasses.
On every visit, I reinforce UV protection to them
Yes.
because that's again very, very important.
Very
I had a guy whom I did the highest I do is 100 microns of central ablation and with a good amount of mitomycin, like 30 seconds is what I use
Yeah.
for those high ablations. He went skiing 1 year after, that was a -7 or something I treated, -8. Good counseling, 1 year doing extremely well, went skiing for a month in Europe. After a year of surgery, came back with severe haze. So those are things which you will be.
Yes.
Okay, final question for each one of you and then we finish the
the
course.
UV protective glasses should be for your SMILE Extra patients, because we've had patients SMILE Extra works
Yes,
wonderfully
yes.
well,
All
Yes.
but
cross-linking, all cross-linking.
the cross-linking, so they may develop UV pro.
Agree.
yeah.
So we are finishing off by one last question and finish it in one line. What percentage of your practice, and I'm going to ask each one of you, is now PRK, lenticule and LASIK?
Okay, so the proportions have changed in past 6 months. So if you ask me last year, it was 40% LASIK, 40% trans PRKs, but now it would be 30% LASIK, 30% SMILE or extras combination, maybe 20 to 25% trans PRKs and then Fakicals. Because what we have seen is, again, sir, your experience is saying the same, the SMILE extras work very well. And if you want to reduce the chances of, don't want to have haze, pain and everything after surgery, then I think SMILE Extra is one option what we give. If patients are traveling abroad or if patients are into occupation where they cannot follow up, we do a lot of SMILE Extra. So that's why the dynamics have changed.
CFS,
50 to 60% lenticule, KLX, 20% PRK and just 10% flaps.
right.
Flaps are only for the high.
And Kumar's place, Shivani?
Flaps, LASIK, followed, and now we've started increasing lenticule. So LASIK and lenticule mostly, less of PRK.
And Kamal's place?
So till maybe 8 months ago, we were around 20% surface, and now it's less than 3-4% because me being the boss, I'm not doing it, so my other surgeons are also.
What
stopped
about
doing it.
lenticule and LASIK?
Lenticule? We just discussed with you. We're going
Oh,
into
yeah,
the
yeah,
lenticule.
absolutely.
We're picking up the machines now.
And Dr. Chitra, your place has had lenticule
In
for a
our
long time.
patient, is 75% is lenticule. High cylinders, though SMILE is doing very well, we do Contoura LASIK. And for corneal thickness, which is less than 490, we do PRK, or we do PRK if the patient cannot afford other procedures. Even if it is 500 plus, we would do PRK for those people who offer some job training and all that.
Sure. Thank you so much,
Thank you.
everybody, and thank you all the faculty. We'll have a quick picture and then we leave. So in my practice, we are doing now 60% lenticule and about 20% PRK and 20%, but I'm not counting ICL in this. We have picked up a good amount of ICL. I mean, phakic lenses have picked up a lot. Is it? True, true.